Good morning, Professor. My name is Daniel Chancellor, and I am doing a 360 integrity check for my abdominal video exam. My patient is over there, and there's nothing in my ears, and we're gonna dive right into the exam. Before we start, I would like to grab a consent for my patient if it's okay for me to record this video and post it on YouTube as Unlisted for my professor to assess my skills for abdominal exam. Do I get a consent to do that?
Yeah.
All right, thank you. Did you get a chance to empty your bladder before the exam?
Yeah.
All right. So this is an exam for the abdominal contour, and I'm going to ask my patient to lay supine. We'll place the pillow, excuse me, under her knees to relax those abdominal muscles during the exam, and then I'll provide drape for privacy because we're going to expose the umbilicus, the pubis symphysis, and I'll ask my patient to raise her shirt to the clavicle borders. And I am kneeling because my exam table is a little bit lower to the ground, so I have to kneel. And I would be examining from the right side, because of the couch, I'm on this left side, so I have to state that. And I have a ruler and a marker for measurements of the liver. All right, so the first step in the exam for the abdominal contour is to inspect the abdomen cavity. You're looking at the symmetry of it, looking for the color in comparison with the sclera. So the color should be normal finding per ethnicity. You're also looking to see if there's any scars, any lesions, rashes, any pulsations in the aorta, or any peristalsis. If someone had a bowel obstruction of that nature, you probably see the peristalsis moving of the bowel. And also I'm looking at the umbilicus to see if it's symmetric on the middle, and also looking if there's any umbilical hernia. Then the next step is going to be auscultation of the abdominal contour, and I am listening, auscultating from the right lower quadrant, listening for gurgling, tinkering, pinkering of the bowel sounds, and no more active in the right lower quadrant, and I move up to the right upper quadrant, and no more is between 5 to 32, and no more in the right upper quadrant. I move on to the left upper quadrant, and also listening for any abnormal sounds, and then you finish at the left lower quadrant, auscultating in patient. You listen to 1 minute to 5 minutes in each quadrant. After auscultating the bowel sounds, now I'm going to auscultate the arteries in the abdominal cavity, starting with the aorta, which is right above the umbilicus, and you auscultating for bruits or any turbulent sounds. The aorta branches off to 2 renal arteries, which are right above the umbilicus, bilateral. So if I had a scope that has a bell and a diaphragm, I'll listen to both sides. So that's the renal arteries. And right below the umbilicus is the iliac arteries, and you listen bilateral. Also listen for bruits or turbulent sounds. And right under the pubis symphysis line, I have the femoral arteries, and you listen bilateral, also listening for bruits and any turbulent sounds, vascular sounds. After that, I would want to listen to the organs that are in the cavity of the abdomen, and on the right upper quadrant is the liver, and right under the gallbladder. So auscultate, listening for any hepatic friction rubs, and there's none. It's normal finding here. And then between the 10th intercostal space on the anterior, I am listening for if there's any splenetic enlargement, friction rubs. After auscultating now, I am going to percuss all the 4 quadrants, and we'll begin percussing in the right middle finger and striking it, listening for timpani sounds. In the right lower quadrant, and then you go up to the right upper quadrant and timpani there. Left upper quadrant, timpani. Left lower quadrant, timpani. And then the bladder should be a tympanic as well, because she emptied her bladder. If she didn't, she got 500 or so, it's going to be a dull sound in the bladder, but in this case it's a tympanic sound. Then I'm going to go to the abdominal organs and percuss as well. So you want to start in the mid umbilicus region, and you percuss in this timpani, and where you hear the dull sounds, that's the bottom of the liver. So I will then get my marker and put a mark there, and then between the nipple line, I'll start just a little bit up above and percuss in between the ribs, because you're going to get a dull sounds if you percuss on the rib, because it's a solid structure. So in between the ribs, you're going to find the lung cavity. So that's going to give you a resonance sound. So resonance sound, and then dull sound. So then I'll mark here and get the 2 points together. That'll be the vertical height of the liver, and it's about 7 centimeters. Normally between 6 to 12 centimeters is normal. And then I would also percuss on the between the intercostal space of the left upper quadrant anterior, and that's the spleen. And we shouldn't be able to feel anything because the spleen is tucked under. And if we're able to get any feeling of it, it means that she's got a enlarged spleen, and that's abnormal finding. You'd want to follow up with that. After percussing the abdomen and organs that's in the abdominal cavity, now I would like to palpate, and you start with one hand in each quadrant. So the initial is 1 to 1 centimeter, and that's just a light palpation to get the patient to be adjusting to your temperature of your hands and get the giggles out. Right upper quadrant, no abnormal findings. Left upper quadrant, no abnormal finding, and left lower quadrant, no abnormal findings. Now the deep palpation, now we're going to go 2 hands and go between 5 to 8 centimeters deep, and you are feeling to see if there's any discomfort. You look at the patient's face, and she can also tell you if she's having any discomfort as you deep palpate, and nothing there. And right upper quadrant, nothing. Also feeling or seeing if there's any masses anywhere. And then left upper quadrant, you palpate, no abnormalities there. Left lower quadrant, no abnormalities there. And now I'd like to perform some tests. The first one would probably do the rebound tenderness, which would indicate if there's any peritoneal infection of some sort. So rebound tenderness basically is to press, give some force down, and you let go and ask the patient if they're having any pain. And in this case, there's no pain because it's a normal finding in our patient today. And then you also would like to do the Murphy's sign, which is on the right upper quadrant, right where the liver is, in the mid upper gastric area, in the right upper quadrant. And I'm going to ask the patient to take a deep breath and breathe out and breathe in again. So then I'll palpate and give some pressure in there, and if patient sees us breathing as I inspire, it presents that there's an indication that there's something wrong with the gallbladder, possibly cholecystitis or some sort. So you want to follow up with that. And then the next test that we could do for the appendix on the right lower quadrant, we try to see if there's any appendicitis or anything of that abnormal in that region. And you'd find McBurney's point, 2/3 in between umbilicus and right iliac crest, and you'd put some pressure there, and when you let go of patients that they have in pain in that area, that's a positive Murphy sign. If my patient had a situs, they're going to present with a protruding abdomen, and all over the abdomen is going to be a dull sound because they have fluid in the abdomen. But when I ask patient to lay on the one side, the fluid would shift, so we'd have tympanic sounds on the outside of the abdomen, on the opposite where she's laying. When you turn it this way again, it will be a tympanic sound and dull everywhere else. That's because the fluid has shifted. And the test we can do for that is a fluid wave test. I would ask the patient, but in the case that they have ascites, it's probably going to be a bit painful. So I would ask a different staff member to come and help to put their hand there a little bit firm, and then you would tap on one side, and you'd feel like a wave will hit your other opposite hand, and that's going to be a positive fluid wave test that they have ascites. We did the rebound tenderness. That's just giving pressure and a quick release, and if there's pain, that's positive for peritoneal cavity, some sort of infection. At this point, I would ask my patient to sit up so we could check the intercostal, vertebral intercostal angle tenderness, which can be signs of pulmononephritis or any sort of renal related issues. And you'd find your 12th rib in back here, and then you want to put your hand facing that way, and I'm going to percuss with my dominant hand. This will be indirect. The direct would just be my right arm striking against this area, and if there's pain, and then that's indicative of pyelonephritis or anything renal related. But in this case, I'll do the percussion with my dominant hand, which is indirect, with one hand laying on the back side, and you strike. No pain there. Bilateral, no pain there. And the patient has no abnormal findings, and that concludes my exam. Thank you very much, Professor.